Good afternoon and welcome everyone to our in-depth look at a controversial issue within the field of ABA. My name is Brandon Gillespie, and with me is Erica Allen, Sydney Heather St. Myers, and Shelby Wainwright. Today, we'll be looking at an issue that affects many of us in our work lives, the battle between empowering our clients to make decisions and have autonomy in their decision-making, and making these decisions for clients in order to provide the best care. From the moment that any child is born, parents start planning and preparing themselves to make decisions to act in the best interest of their child and give them the highest quality of life. Children diagnosed with ASD are no different, but often offer unique challenges to parents and caregivers, as they may need additional supports throughout their lives to really be given the best chance. Throughout history, there is a clear pattern that many clients were denied rights to make such choices within their treatment, and more often than not, these cases ended in disaster. Cases such as the Sunlight Chemicals in the 1970s offer a brief glimpse into the potential abuse and harm that can come from clients, and those in power are blindly trusted with making decisions for their clients. Since then, however, the BACB ethical code and core ethical principles of our field have been further developed in order to prevent anything like this from ever happening again. Despite that, there are still situations that all behavior analysts encounter, in which they are put in the position of making a decision for the well-being of their client. The key issue we'll be discussing today are both sides of the argument against and for the empowerment of clients. Beginning the conversation is Shelby with the first of the empowering clients' major arguments.
Thank you, Brandon, and hello, everyone. As Brandon mentioned before, I will be discussing the first major point for the empowerment of the clients, which states individuals have the right by law to make important decisions regarding their well-being. Individuals with disabilities need support, but ultimately should be able to make their own decisions. With supported decision-making, like individuals without a disability, those with disabilities can consult with others regarding important life decisions. Heather will help support these arguments by describing our findings.
Thank you. The Center for Public Representation in Northampton, Massachusetts has a website titled Supported Decision Making that is copyrighted in 2018. The website states, supported decision-making is an alternative to guardianship. Supported decision-making allows the person with a disability to make his or her own decisions instead of having someone else make them for him or her.
Thank you, Heather. Based upon this graph, 67% of the families within the study believe that making supported decisions gave the individual an opportunity to gain more confidence. 61% of the individuals within the study, families noticed a happier demeanor within their loved ones. They believe that by having someone to help them with making decisions, their loved ones were given the encouragement to try new things and be able to engage in activities that they typically would not be interested in. 28% of the individuals engaged in the study believe that making supported decisions gave them the opportunity to make and sustain more friendships. Everyone needs support with making decisions. Even individuals without disabilities tend to rely on their support circle for advice and encouragement when making important life decisions.
Supported decision-making promotes self-determination, control, and autonomy. It fosters independence. Those with disabilities may require assistance in the decision-making process when it comes to finances, living arrangements, healthcare, and relationships. It's not always required that they have a guardian to solely make those important life decisions. Typically, individuals consult with their family or friends when making important life decisions. It shouldn't be considered a handicap for individuals with disabilities to do so too. People who are under guardianship have been reported to experience civil death due to the decision-making of their important life matters not being in their control.
On the same website from Massachusetts titled Supported Decision Making, civil death is a term used when people lose the right to make their own decisions and a guardian makes them for them. At least 1.5 million adults are under guardianship in the United States, but this could be a lot higher due to a lack of complete data. This number is expected to grow to several million by 2030.
As Heather stated, the number of individuals under guardianship is expected to increase at a rapid rate, which can also increase the number of individuals who may experience the loss of being able to make their own decisions. These are alternatives to guardianship, the most effective being supported decision-making.
Supported decision-making is a good alternative to guardianship. Although this is a newer paradigm shift in the United States, the concept has been taking form in other countries for more than a decade, according to the Massachusetts Center for Public Representation.
Strategies to build networks of support for individuals with disabilities has been shown to take stress off the caregivers while giving the individual a voice.
London's Inclusion International website, copyrighted in 2018, contains an article titled "The Right to Decide: Why Does It Matter?" It states, adults who are not allowed to make their own decisions are less vulnerable. One powerful quote from the site stated, "A lack of options restricts choice. It does not restrict voice. Limited options should not restrict goal setting. Something may not be available now, and it may take time, but it doesn't always mean it is impossible." The site gives some specific ideas in the following. Families have to believe that their sons and daughters have a voice and are able to express their own decisions. To support this, families can learn more about how people are supported to make their own decisions, encourage their sons and daughters to develop decision-making skills as they grow and develop, provide information in plain language and help identify implications and consequences of decisions, and expect their sons and daughters to have opinions. Rely on behaviors and other forms of communication as an expression of will and intent, and use that to guide decision-making. Acknowledge that mistakes will happen and that we all learn from making mistakes. Commit to supported decision-making. Establish a support network or circle. Reject pressure to seek guardianship orders.
Next, I'll be discussing the first argument from the clinician care side. While giving clients total empowerment and autonomy over their care would be ideal, clients have shown they may not always make the most responsible decisions for themselves. According to Smith and Bell in 2006, clients, when given free choice regarding food, will often choose the unhealthy option.
Like Fred and Brandon said, according to Smith and Bell, there are many factors that go into someone making a choice about something as simple as food. These factors include issues surrounding the individual as well as the caretaker and the environment. Factors that affect the individual, including their cognitive ability. This is whether they are able to understand their choices as well as their lifestyle. This is limited exposure to making healthy choices. Other factors include their socioeconomic status, which can affect choices due to the individuals with learning disabilities being dependent on benefits from the government. This will greatly limit their choices due to cost. Another issue is past experience with choices. If these choices are not being supported, they will most likely go to choices that were previously reinforced in the past. There are other issues that can affect choice of an individual, such as their lack of knowledge or lack of awareness to learn about choices, their degree of dependency. Those who have milder disabilities have less restrictive environments and are more likely to have issues with obesity, as well as physical ability and oral and dental health. Individuals with disabilities often have higher rates of dental disease as well as unmet oral health needs. This can lead to them choosing things to eat that are softer to overcome the difficulties with oral health. These are some of the main issues an individual faces when making choices. Other environmental and environment of the individual as well as the care provider. Issues with environment and care providers can include the care's ability to teach individuals how to make healthy choices as well as duty of care. Duty of care is important. While the care should promote the individual's choice, the care also needs to ensure that the individual understands the choices they are making. Overall, the main issues with an individual with learning disability making choices is the individual does not fully understand the consequences of making a choice. This is important to understand and identify. A person with a disability cannot fully make a choice if they do not understand the choice.
Thanks, Sydney. This is one of the many examples of clients not always acting in their best interest when given free choice. One of our core ethical principles is to do no harm, and it could be argued that allowing a client to make decisions that are not in their best interest, such as only eating unhealthy food or ignoring social and physical activity, that the behavior analyst would be knowingly acting in such a way that harms the client. The counter to this line of thinking is that all individuals, typical or not, often struggle while making decisions in their best interest. I know personally that I enjoy a tub of ice cream or McDonald's more than I probably should. If a typical person is allowed to make decisions against their best interest, why too can't somebody with ASD make these same mistakes? It's an interesting question, and one that I personally think boils down to the level of functioning of the individual in question. An individual diagnosed with ASD may not have the same level of understanding of the consequences of their actions, like Sydney mentioned. I understand that if I eat a whole tub of ice cream every day, I'll likely gain a large amount of weight and possibly have other health complications from making this decision. Somebody with ASD may not fully understand the consequences their actions will have down the road, but rather prioritize the immediate satisfaction of eating unhealthy foods over the long-term health consequences that they may not potentially understand. Next, we'll go back to Shelby for another point on the empowerment side.
Thank you, Brandon. Giving clients the choice between effective treatments has shown to improve outcomes. Allowing clients the choice between effective treatments defines independence and offers information on decision-making, managing risks, and building a support system for individuals with disabilities. The lack of options for those individuals are limiting their choices. Individuals with disabilities should not be assumed to be unable to understand scientific treatment options, but instead should be educated about these treatments, like someone without a disability would be. When someone goes to the doctor needing medication, typically the doctor will discuss medication options, explaining the side effects and benefits from each medication. The doctors may even give recommendations that best fit the patient. Individuals with disabilities deserve the same courtesy in a way that they can best comprehend. Yes, they may still require supported decision-making for their from their care team, but they are involved in the process.
In 2006, W.S. Prey wrote an article in American Journal of Pharmaceutical Education titled Ethical, Scientific, and Educational Concerns with Unproven Medications. Prey showed that clients may choose treatments with little to no proven efficacy. Bannerman D.J., Sheldon J.B., Sherman J.A., and Harchick A.E. included an article in Journal of Applied Behavior Analysis in 1990 titled Balancing the Right to Habilitation with the Right to Personal Liberties, the Rights of People with Developmental Disabilities to Eat Too Many Donuts and Take a Nap. They stated that we also can't simply allow people to make total choices with no support. And if somebody loses all motivation simply because they don't have total involvement in their decision making, they likely won't make it far with self-empowerment.
The second main argument on the side of clinician care is that our clients are not making decisions based in empirical evidence. According to Prey 2006, clients may opt to choose treatments that have little to no scientific evidence behind them.
Like mentioned earlier, Prey 2006 focuses on the overarching issue of pharmacists selling and endorsing non-scientifically supported medicine to their client base, and many of the reasons for this. One such reason that was cited, and the one most pertinent to our discussion, was client demand. Prey cites a study that has been done in 1990 that surveyed 2,039 U.S. households. In this study, it was found that 85% of these households were using at least one form of alternative medicine. Prey continues to describe why this can be an issue with pharmacists supporting these treatments involving liability.
Absolutely. This point Prey raises about liability directly applies to us in the field of ABA, because allowing someone to make a choice that doesn't involve empirical evidence is that it goes directly against a couple of our ethical guidelines outlined by the VACB. The first of which is 1.0 run, a reliance on scientific knowledge.
The following VACB Compliance Code 1.01 states behavior analysts rely on professionally derived knowledge based on science and behavior analysis when making scientific or professional judgments in human service provision, or when engaging in scholarly or professional endeavors. One of the primary characteristics of behavior analysis is our reliance on scientific evidence as a basis of our practice. We value single subject design studies that clearly demonstrate functional control of behavior, which additionally point to effective interventions that are also evaluated carefully with clinical data.
This coincides with 2.09a as well, treatment intervention efficacy.
Definitely. The Compliance Code 2.09 refers to clients' treatment. Clients have the right to effective treatment. Behavior analysts are obligated to advocate and educate clients on the most effective, scientifically supported treatments. When there are more than one option, we are to consider the efficiency, cost effectiveness, risks, side effects, client preference, and their physician's experience and training. This also relates to the table. This table here, which shows the percentage of individuals with ASD that receives recommendations on healthcare transitions. It is many times that families need assistance with these transitions. However, as you can see here, the numbers on this graph shows exactly how little individuals receive recommendations with their healthcare transitions. Only 14.9% of the individuals within this study have received adequate information regarding healthcare transitions, where 85.1% of the individuals have not. Those numbers are drastic, and it is the responsibility of the behavior analyst to make those needed recommendations so that individuals are getting adequate healthcare services. If a person does not receive the information about adult care from anyone, how are they supposed to make the appropriate decisions?
Thanks, Erica. We have an obligation to our client base to advocate for the best and most effective treatment, and we judge this based on the long-term and short-term benefits for the client. When we cannot verify these benefits with science, we cannot agree to these treatments in good faith. The counterpoint to this train of thought, once again, comes from the idea that typical individuals are going against conventional treatment choices every single day in the form of essential oils, herbal supplements, and other fad practices. Once again, if typical individuals are allowed to make these mistakes, why too shouldn't individuals with ASD be allowed to make these choices? Yet again, I think the distinction here lies in the ability of a typical individual to understand all the options available to them. Many individuals with ASD may not fully understand the difference between pseudoscience and empirical science and the implications involved with this difference. In order to make empowerment a possibility with our client base, we first have to evaluate the merit of treatments and properly educate and make sure that our client base fully understands both treatments and their proven values. Here's Shelby with the final set of empowerment points.
Typically, developing individuals gain support in school to aid their success in adulthood. Individuals with disabilities should gain the same amount of support. For typically developing individuals, there is a vast amount of course options that help aid these students for life post-school. Courses like these should be available to individuals with disabilities that specialize in their needs as well. For example, courses that offer self-determination training to ease the transition from school to adulthood have proved to be successful. If schools made it a priority to provide these skills and a safe setting to practice these skills, success in the future would be a lot more feasible. Heather will now explain some of the school-based factors that positively affect the post-school outcomes for individuals with disabilities.
In 2014, Gregoudis Stelios, in preparing students with disabilities to transition from school to work through self-determination training, stated, for students to acquire self-determination skills, they need instruction and safe settings in which to practice such skills. Sjogren Carey A., Garnier, Villarreal, Mauricio, Lang Kyle, Seo Hyojong wrote, meditating role of self-determination constructs in explaining the relationship between school factors and post-school outcomes. In 2017, Exceptional Children. Given the relationship between self-determination and in-school and post-school outcomes, researchers have suggested that self-determination, and more specifically, student autonomy, self-regulation, psychological empowerment, and self-realization potentially mediates the relationship between school-based factors. Examples are student factors, family involvement, and transition practices and outcomes.
As Heather showed, promoting self-determination may further enhance the effect of other school-based factors, such as inclusive opportunities, promoting access to general education, curriculum, increasing social skills, making family expectations and outcomes more positive. These skills can be taught to aid students with disabilities in their transition to adulthood.
The Exceptional Children article lists skills that should be taught in school, such as social and communication skills and self-advocacy skills. These, along with parent knowledge and involvement in transition, assist with student self-determination.
And to add, IEPs tend to be more teacher-directed than student-directed. These are individualized plans. Students who are able should be involved in the goal-setting process to help with the steps to meet the goal. This allows more independence in their educational careers, preparing them to be more independent in their adult lives.
Although federal special education legislation and the self-determination movement have promoted and increased students' attendance at their individualized education program meetings, students' active involvement in the IEP process remains limited. The following graphs are from a study that used the self-directed IEP with 5 students, in which identified with a variety of disabilities to increase participation in their IEP meetings. The self-directed IEP is an evidence-based instructional practice that teaches students to become active participants in their IEP meetings, with coaching being provided as needed by the teacher who taught the lessons. Over time, students use their learned skills to lead their IEP meetings. The results on each graph indicated a functional relationship between the implementation of the self-directed IEP and increased student participation in IEP meetings. Furthermore, students were able to generalize their newly acquired skills to their real IEP meetings.
In Griguda's article, it discussed the need for the student to select his or her own learning goal, then put together a plan to meet that goal, take action, and determine whether the plan worked and what adjustments need to be made. Teacher must provide support, such as enabling students to identify their interests, strengths, and abilities, and assisting students in gathering information about their opportunities.
Thanks, Heather. The last point on the clinician care side of the argument comes from the background of do no harm and a core ethical principle associated with it. This point relates to the idea that our client base is a vulnerable one, and one that may not have the capacity to understand the dangers of the environment around them, or even potentially dangerous in themselves. According to Fisher et al., individuals with intellectual disabilities were not able to appropriately respond to lures from strangers without an intervention.
Like Brandon said, according to Fisher et al., individuals with disabilities were unable to consistently generalize during in-situation assessments. In the follow-up assessment, 2 of the participants in the study were able to consistently meet criterion. However, the other 3 participants had varying results. It is important to note that the individuals within this study did not consistently say no to the stranger. However, they failed to report the incident to an adult.
Like Sydney showed, this population is one that is particularly vulnerable if given complete autonomy and no potential care decision is made for them. In addition to this, according to Hill et al., of their sample of 25% of ASD were found to possess aggressive behaviors. In a population with rates of aggression conservatively estimated at 25% from this study, it may prove to be dangerous to others and the individual to allow somebody complete empowerment in their care. Some individuals would opt to do nothing about their aggression, self-injurious behaviors, and if we give them complete decision-making power, we'd be accepting potential harm to befall our clients or society. The counterpoint to this side of the debate would be the mention that while individuals with ASD may not be instinctively knowing these behaviors without training, they can learn protective behaviors like any typical person can. In the very same study, the Fisher study, participants and families all reported feeling more comfortable being alone and safer as well. After receiving the proper training and learning the proper responses, the individuals did well in reacting appropriately. In addition, typical individuals often take self-defense classes and various safety trainings. There's absolutely no reason why an individual with ASD could not do the same. Much the same as a typical person may not know how to properly do something without training, it's only fair to expect the same for an individual with ASD.
All in all, I think we can all agree that the best option always found in striking a balance, whether or not someone has been diagnosed with a disability, everyone requires some degree of support and allowance to be independent. Compromise is necessary to provide the best and most effective treatment. We need to strive to empower our clients to the best of their functional level Give them the most choice and independence that they can manage while still acting within their scope of understanding. Total empowerment doesn't work for everyone, but total clinician power and decision-making doesn't either. And now Cindy will open up the floor for some questions.
Here are some questions that further the conversation. What must analysts do to help families plan for transitions? Okay. According to Henniger and Taylor, families believe a successful transition would allow individuals with developmental disabilities to be as independent as possible, as well as having a productive life and job. The main concerns families have are employment, independent living, and relationships. For an analyst to be able to help families transition, the analyst should work on functional living skills that the individual would need to live as independently as possible. The analyst should also provide families with information related to vocational schools and trainings that would better prepare the individual to find a job. Second question, how can school districts better prepare children with disabilities to advocate for themselves during the transition to adulthood?
Children need to be taught how to advocate for themselves. This is not a skill that is easily understood or picked up from watching other people. It needs to be explicitly taught. What does it look like to self-advocate? What are some ways that I can advocate for myself? A school should provide examples, model, and provide practice. Students should be involved with their goal setting and IEP meetings. If decisions are always made for a student or discussions are held about them instead of with them, they are not given the chance to tell what they need or want. Students should be in their IEP meetings providing feedback on how they think they are doing and what they need to be successful from an early age. Students must be involved by the time transition planning is occurring, but many schools allow participating in different ways. Students do not want to sit through a full meeting, but it is the school's responsibility to teach a child how it is important to advocate for themselves during these meetings. A school must also provide transition information to a student and their family. Many individuals do not ask for the best services because they did not even know what was available. We learned in our research that schools need to do a better job at making sure the information is provided to everyone and that help in accessing the resources is available.
Very well stated, Heather. For question number 3, how can parents and guardians teach children with disabilities to advocate for themselves to increase self-determination?
Self-advocacy is an individual's means of communicating in order to effectively convey, negotiate, or assert their own desires, needs, or rights. It involves making informed decisions. The first step to advocate your rights is self-knowledge, being aware of your own strengths and weaknesses. It is important that these self-advocacy skills be learned early. Self-advocacy begins by learning how to make your own decisions. These decisions can be as simple as what to eat, what activity to engage in on your leisure time, and what clothes to wear. Some steps caregivers and parents can take to teach their self-advocacy skills early on are teaching the child to communicate yes or no, encouraging the child's interest and supporting it, demonstrating to the individual how to work through problems calmly and rationally. They'll be more likely to do the same when they're older. Teach the child to request help appropriately, role-play scenarios that may arise at school and how to work through them appropriately. Enroll the child in ABA, counseling, speech therapy, and or any other activity that will aid the child in learning functional communication skills. As the child gets older, you can have them order at a restaurant using their own communication system, run errands with the child to teach them the concept of time, and teach them to make personal decisions about purchasing items and budgeting. All of these are smaller skills that help lead to the acquisition of more difficult skills and increase self-determination.
Very nice. Very nice. Our fourth question is, when is it not in the child's best interest to let them advocate for themselves?
I think the biggest consideration in having clients advocate for themselves comes back to something that we brought up earlier. It comes down to the behavior analyst having a firm understanding of their client and what their capabilities are. Understanding the level of functioning of your client is crucial in deciding on the level of involvement that they'll have. And a very high functioning client may be better able to understand that the doctor is telling them a prescription will help them recover from an illness. And that when the doctor tells them this, they do so because they have scientific basis for it. Whereas a low functioning client may hear promises of essential oils or other treatments and decide these are easier than the prescription, or may not understand either option at all. So the answer to the question is really that it depends on the client and on the issue as well.
Thank you, Brandon. Our final question is, when should children with disabilities start advocating for themselves? Self-advocacy is something that should be taught and utilized as young as possible. However, in some cases, self-advocacy may be more difficult to utilize due to an individual's functioning. However, self-advocacy should be taught and utilized based on the age and what is age appropriate for an individual. For an example, a child in elementary school who understands that they have accommodations should advocate for themselves to receive their accommodations. Overall, an individual with disabilities should begin advocating for themselves when they have an understanding of their disability as well as an understanding of their needs and how to communicate those needs effectively.
Very well put, Sydney. Thank you all for watching and hopefully gaining a better understanding of the core issue we've been discussing this afternoon. Have a fantastic rest of your day, and remember, compromise and balance is key when it comes to empowering clients.